Now, what is periosteal reaction or what is periosteal elevation? Just try to understand. Imagine this is a bone, all right, and the bone is covered by the periosteal layer. All of you are aware of the fact that it is having a periosteum. Now, in the periosteum, we already have discussed that periosteum is fairly categorized into two parts, the inner and the outer layer. You know, the periosteum is actually not the fibrous covering of the bone. It is actually having two layers, the inner layer and the outer layer. You know, outer layer is the fibrous layer, which is responsible for protecting the inner lying structures. But the inner layer is the cambium layer. And you know, this cambium layer of the periosteum is responsible for the formation of the bone. All right. This cambium layer of the periosteum, it is responsible for bone formation. It is contributory to bone formation. And it is also responsible for increasing the width of the bone. All right. Because it has got osteoprogenitor potential. So, bone formation, increasing the width of the bone. So, this is the normal physiological function of the cambium layer of the periosteum. Width of bone is increased by this cambium layer. All right. So, by this time you came to know that periosteum is not just a single fibrous layer which is protecting the bone. It is actually made up of two layers. One is inner layer, outer layer. The outer is just a fibrous layer, but the inner is a cambium layer which is responsible. It is contributory to the addition of layers of bone to the already existing bone. It is responsible for increasing the width of the bone. It has got osteoprogenitor potential. All right. Now, just imagine if there is an organism which is present inside. Imagine there is an organism and it has led to the formation of the abscess following the inflammatory processes. Now, this organism will try to move or will try to spread. Now, this spread of the organism will be prevented by the additional layer of the periosteum. It will lead to the formation of a bony wall in order to prevent this organism to move out of this restricted zone. But if the organism is virulent enough or if the organism is fulminant enough, then it will progress further. So, the bone will take another attempt or the cambium layer of periosteum will take another attempt to limit the progression of this abscess or the organism. Similarly, multiple layers of the periosteum will be laid over a period of time. Now, what you will clearly see that after some duration of time, what is happening, that initially the periosteum was present around the edges of the bone, but after some duration of time, you can very clearly see that the periosteum has moved beyond the confines of the bone, or periosteum is elevated beyond the confines of the bone, and this is what is known as periosteal reaction or periosteal elevation. Now, this periosteal reaction leading to its elevation will not appear immediately. It will take some time for its appearance, and that time duration is 7 to 10 days. Hope you have understood everything related to the X-ray findings. So, two X-ray findings that you have to remember in case of acute osteomyelitis. One is the obliteration or the loss of the soft tissue planes, and the second one is the periosteal reaction or periosteal elevation. Next investigation that is essentially very important is the ultrasonography. Remember, whenever a child comes to you and you are suspecting him to be suffering from acute osteomyelitis, then instead of jumping on to the investigation of choice, that is MRI is considered to be the investigation of choice. You see, instead of jumping to the investigation of choice directly, you have to go with the USG in order to localize the abscess, in order to see the loculations, that where exactly the abscess is located and what should be your approach in the management of that abscess. All right. So, better to go for the MRI immediately. You have to go, or a preceding investigation is always the USG for localization of the abscess. You know, because the density of the bone is not that greater, abscess which is located inside the joint or abscess which is located outside the joint could be easily delineated or demarcated on the USG itself. That is why in case of a child, better to go with the USG first and then go with the MRI. In case of adults, better to go with the MRI, not with the USG. Hope you have understood what I'm trying to say. So, it all depends what the language of the question the examiner is asking. In case of a child, if you are suspecting him to be suffering from acute osteomyelitis and you want to confirm your diagnosis, go with the ultrasonography. While in case of adults, you can go with the MRI. And then finally comes the management. Now, by this time, you already have made the diagnosis that there is a collection of the abscess. inside the bone or outside the bone, you have to drain it. So what you have to do, first of all, as far as management is concerned, empirical antibiotics are to be given as early as possible, and following which you have to perform the drainage. So incision and drainage. Now, if there is a presence of the abscess, or if there is a presence of the organism within the bone also, or inside the bone also, then in that case you have to perform the, you have to create a window. But most of the time, this abscess which is present outside the bone, if it is moved out or if it is drained, then subsequent continuation of the antibiotics would be leading to the complete recovery of the condition. Because the possibility of the complications associated with the window creation is that you might add the organism inside the bone. All right. So incision and drainage is considered to be the management. Now, as far as the role of antibiotics are concerned, appropriate antibiotics after pus culture sensitivity, you get the pus culture sensitivity report. The appropriate antibiotics are to be given, and those antibiotics are continued for the period of 2 to 3 weeks in the form of IV antibiotics and 4 to 6 weeks in the form of oral antibiotics. All right. So first IV antibiotic for the period of 2 to 3 weeks, and then switch on to the oral antibiotic for the period of 4 to 6 weeks. That means the span of the management of this acute osteomyelitis condition is long. You are treating a condition which might take around 6 weeks to 10 weeks. That means 1.5 to 2.5 months of the antibiotic management or the drug related management. Hopefully you have understood everything related to the question or topic in particular, that is acute osteomyelitis. So right from the appearance up to the management, this is how you have to go for. Now, one thing is also said, like, you know, in case if you are whatever the pus you have drained out or whatever the abscess that you have isolated, this abscess should be sent for pus culture sensitivity as well as histopathological examination. Why histopathological examination? Because it clearly mimics, you know, the condition of acute osteomyelitis is very closely mimicking that of Ewing sarcoma. All right. So histopathological examination is also required in order to rule out this Ewing sarcoma if the patient is suspecting to be having this. So pus culture sensitivity and Ewing sarcoma of the aspirate that you have obtained. As far as complications are concerned, you know, it is just related to the timeline of the management. Just imagine a patient who is suffering from acute osteomyelitis is obviously not, most of the chances are that he is obviously not coming from a good socioeconomic status. He is coming from a poor socioeconomic status, and the continuation of this antibiotics for a long duration of time, the patient might lose compliance. And because of this lack of compliance, some amount of the organism will persist inside the bone. And that persistence of the organism inside a bone for a long duration of time might result in chronic osteomyelitis. All right. So ill treatment or maltreatment of a condition that is acute osteomyelitis might result in chronic osteomyelitis. All right. So that is considered to be the most common complication, which is very, very commonly seen, that after the incomplete management of acute osteomyelitis condition, the patient is getting this condition is getting converted into chronic osteomyelitis. Now back to the question. The sample question which I provided to you in the beginning of this topic was that a 5-year-old male was brought to the OPD 5 days after sustaining injury to his right thigh. Now you came to know why injury is important. Second, on examination, there was swelling, there was limitation of movement and fever, but the x-rays were no fracture, means x-rays were insignificant. So what next you have to do? Now apply a long leg slab and start oral antibiotics. You know, long leg slab and oral antibiotic, if you are applying a slab, then possibly you are thinking that the patient is having a soft tissue injury. All right. Second, start IV antibiotics and shift the patient to ICU. You see, this is not such a condition in which you have to treat the patient in intensive care unit. Option number 3, start IV antibiotic and get the ultrasonography done. Now, this is something which is going to reveal that possibly the patient is suffering from acute osteomyelitis. So this is considered to be the best answer out of the multiple options which are provided to you. And perform urgent arthrotomy and drainage. You know, arthrotomy means opening a joint. You don't have to open the joint until and unless it is confirmed that the patient is suffering from septic arthritis. That means joint infections. So hopefully you have understood everything related to this particular topic. And this is why these simple type of the options were provided to you, so that because it happens when you see such a patient in the emergency, then what should be your approach, and that approach is decided by that what next you will do in that particular situation. All right. So before we move on to the next topic, let's have a discussion on the question itself, which is related to that particular topic. That 12-year-old child came with a history of injury to his right leg 9 months back, following which he developed swelling fever 10 days after injury. He was taken to a local practitioner where treatment was done by incision over the swelling. So he made the incision and drained the abscess possibly. Since then, there is a series of intermittent pain, fever and swelling episodes every second to third month. On examination, there is an active sinus which is present on anterolateral aspect of the right leg with the drainage of the abscess and a bony spicule. So bony spicule is coming out of that sinus. What is the most probable diagnosis the patient is suffering from? So before we come on to this particular question, let's have a discussion on the chronic osteomyelitis. Now, obviously, we have talked about that what are the events which led to the conversion of this acute osteomyelitis into chronic osteomyelitis. Now, what are the pathophysiological features? Now, as far as the chronic osteomyelitis is concerned, you know, the clinical features, pathophysiological, radiological, all these features are going to be combined in a single discussion of these 4 subheadings. The first one is sequestrum. Now, just try to understand all these pathophysiological features we'll be discussing in the form of a diagrammatic representation. Now, just imagine if a child was having acute osteomyelitis which was ill-treated, so it led to the collection of some organisms which remains inside the bone. So imagine these are the organisms which are still present inside the bone. Now these organisms, they are growing around a segment of the bone, small segment of the bone. So if the organism is growing around this small segment of the bone, are they not going to interfere with the nutritional supply to that bone? So this bone is going to be deprived of any nutritional supply. And because of this deprivation of this nutritional supply, it will become avascular. So this small segment of the bone will become avascular. So because of the avascularity, it will go into necrosis. And once the stages of the necrosis sets in, so there will be a stage of calcification also. And that stage of calcification will make it more apparent. That means it will make it more dense on the X-rays. So it will increase the density, or it will increase the appearance of the small segment of the bone. All right. Now, this small segment of the bone is known by the name of sequestrum. So this is sequestrum. Now, what we have already discussed, again, I'm revising it quickly, that, you know, if there is a persistence of the organism which is growing around a small segment of the bone, so it will interfere with the nutritional supply, as a result of which this small segment of the bone will become avascularly necrosed. The necrosed segment will become more dense because of the stage of calcification. And this increased density means the organism will also be coupled with, the presence of the organism will also invite the inflammation. And if the organism is present for a long duration of time, that inflammation is going to be a chronic inflammatory condition. And that chronic inflammation will lead to the formation of a granulation tissue. So it will be coupled with the granulation. So what is sequestrum actually? Sequestrum is a segment of the bone which is dead and it is surrounded by the organism along with the granulation. So this is what the definition of sequestrum is. So what we have written over here in the sequestral definition, which is, it is a dead bone which is surrounded by the granulation or the organism. Now you came to know why it is surrounded by the organism and granulation. Now it is having an increased bony particulate on the X-ray. So it is considered to be having an increased or a greater density compared to the normal bony density because of the calcification in the necrosis, surrounded by a radiolucent zone. All right. So this is one about the sequestrum.